So it's my great pleasure to say hello again to Dr. Emma Benn
Hello.
at the AI conference, the new wave of AI in healthcare. It's great to have you here. Thank you for
Thank
joining.
you. Thank you. This has been awesome. Like the amount of people who have come from such different backgrounds and disciplines and from all over, like all thinking about AI in healthcare. This is phenomenal.
And you are a trained biostatistician, so you actually really know how it works. So you can't be fooled with AI talk on top of it. It's a pleasure.
I do not consider myself an AI expert by any means, but I mean, I still think that there is a lot of room for a statistician to contribute and think a lot. Like we were talking earlier about the fact that I think a lot about inference and wanting in healthcare, we want to do something to help patients, right? And thinking about how we operationalize variables like race and things like that in our algorithms. Are we just merely kind of doing something circular where we're just describing differences that we already know exist? Are we finding mutable targets for intervention? So I think I can contribute something to the conversation.
Oh, drastically. For once, for example, Mount Sinai is, of course, a very unique place because we have a very diverse patient population across all boroughs. But one of the biggest issues in the past is even if you want to stratify for biases, for example, in race and ethnicity, the data is usually missing. But Mount Sinai has a huge initiative to actually complete that kind of data.
Yeah, they've been working for quite a while on this. I know Sinai is really committed. I know a lot of people from across the institution, the Office for Diversity and Inclusion, the data scientists, everyone is committed to doing this. But it is tough, right? Like you want to make sure that we have the data to be able to even know what are the demographics of the population we serve. And I think now there's not just a push around race ethnicity, but there's a push around kind of LGBTQIA plus populations, trying to make sure that we're really being able to capture who is in our patient population. And it's necessary, right? Just because of the fact that we know that we have certain populations that are more vulnerable. If we don't know who they are,
Yes.
then it's hard to really be able to identify the problems that we need to tackle that are going to be most relevant to those communities, right? So I'm happy to be part of an institution that understands that this matters.
So one thing along that lines that you brought up was that it's not enough to do the statistics or the machine learning on top after you have these variables, but you have to engage the communities for which we build these AI systems very early on. Can you elaborate on that? Why that makes sense? Why is that so important?
Well, I mean, you know, a lot of people will talk about mistrust in communities of color, right? They'll talk about, well, I don't understand, like they don't want to give their data, they don't want to, right? And the reality is that you can't ignore history, right? And you can't ignore the experience that a patient has with just their physician or their challenges even navigating the healthcare system, getting access to healthcare, right? And so you have to be engaging communities from the beginning. You need to ask them what are the problems that are important to them. You have to talk to them about what data it is that you're capturing from them and how it's going to be used, because we have to be honest. There are well-intentioned researchers who create wonderful algorithms or well-intentioned algorithms that can have unintended consequences, right? And healthcare is one setting, but a lot of communities of color think about, you know, incarceration. They think about how algorithms are used to determine how long their sentences are, right? And so now you're saying, I want to use your data and I want to create an algorithm to determine what decision we should make for your health care, but I'm not engaging you in the conversation from the beginning. and wondering who benefits from their data, who profits from that. All of those types of questions. Communities of color have to be at the table, and just underrepresented, marginalized communities as a whole. Not just for the data, but I also believe in terms of being the data scientists. We have to make sure that we're at the table. That's just equity in its fullest, you know?
And we talked with the FDA before. We want to build AI that's safe and effective, but it should be safe and effective and equitable.
Yeah.
And what's certainly unique about Mount Sinai is, so for computer scientists, also like me, that's of course something unusual and uncommon, that you talk with communities, right? That you're not trained to do that. You never did that. Mount Sinai is the first place I am at where that is really also lived, and where teams like yours and other teams and groups that actually help also the computer scientists to get engaged. And that's certainly something very unique out there.
Yeah, none of us are trained. I think in the area of quantitative sciences as a whole, like, that's not a part of our curriculum. That's kind of a part of the curriculum of social scientists, to be connected with the community. We are to be connected with the data. When we think about ethics and data, we think about data privacy, data security, we think about those things. We sometimes are like removed from the source of the data, right? And so I think that has to change, and you're right. Mount Sinai really thinks about that, and as we're training the next generation of scientists, we're trying to teach them to engage with communities. But you're right, it's not something that is typically expected of us.
Yeah, we can certainly do better there. So in your Center for Scientific Diversity, so that's certainly a big part certainly of what you do, but there's also the statistics and education I know of. What else are you focused on in your center?
Yeah, so when I first got into the field of biostatistics, I kind of looked around and I didn't see a lot of people like me. And so I thought, okay, in addition to doing whatever research I was doing, I really wanted to kind of create a more inclusive environment for more people to come in. But then when I moved into the academic medical space, I saw that we didn't have enough representation in terms of trainees, faculties from underrepresented groups in the biomedical research workforce. And so we weren't realizing our full potential as it relates to innovation in healthcare. So our center, my Center for Scientific Diversity, is very much focused on thinking about diversity and inclusive excellence as a science, thinking about using data to develop best practices for recruiting, retaining, and advancing underrepresented trainees and faculty in the biomedical research workforce. Of course, me being a statistician means that I definitely think about that subpopulation of quantitative scientists, and am doing my work, doing my best to try to make sure that we're diversifying the field. And at Mount Sinai, we have an NIH FIRST grant, like a $16 million grant that is focused primarily on promoting and sustaining academic cultures of inclusive excellence. So I'm really thankful to be a part of that.
Amazing work. Very good, Emma. So one maybe difficult question. We very often at high level talk about that one thing that AI in the ideal case can provide is really democratization of access to healthcare, because currently it's localized, maybe at Mount Sinai or other places. But some of these, that knowledge that's locked up in these ivory towers could be captured by algorithms and then deployed algorithmically in the communities, community clinics around in the US or across the globe. That's a aspirational goal. We do early steps in pathology across the world, but it's very, very aspirational. From your point of view, where would you see the first touch points where we could actually make that a reality, where AI can really bring value to patients in the community who usually, for example, couldn't afford Mount Sinai or other places?
Well, of course, we want all patients to get access to our health systems. But I think that if we could do this in a way that helps kind of lower resource health settings, make decisions, and deliver healthcare in a way that will benefit the patients that they are serving and the communities that they're serving, I think that would be wonderful. The thing is, those clinics, to me, you have to engage those doctors. You have to engage those patients in that process, right? If we're doing it at Sinai and then we're deploying it elsewhere, without kind of thinking of them as partners. Like if we think of this as a partnership, I think that we could really do, quite a bit of amazing work together. But I think that sometimes within the ivory towers, we have the resources, we do something, and then we say everybody should use this. And so I think that if we can establish strong partnerships like Mount Sinai has been doing with the communities, I think that's how we can make something like this work. But it is also going to mean that the technologies that we're deploying are addressing the problems that are most relevant to the communities that these community health centers are serving.
Very well said. Dr. Benn, Emma, thank you so much.
Thank you. It's been real. Thank you.